Our next esteemed speaker is Dr. K Sarin. Dr. Sarin is a senior professor, hepatology and director, Institute of Liver and Biliary Diseases, New Delhi. He's also director, WHO Collaborative Center on Chronic Liver Disease and Viral Hepatitis at the ILBS. He has been awarded Padma Bhushan by Government of India in recognition of his services. 600 publications, chapters, and books, helped in developing 19 major guidelines, including 6 major Asian Pacific treatment guidelines for liver diseases. He is credited with several new treatment protocols for liver disease, especially variceal bleeding, liver regeneration, hepatitis B, and acute and chronic liver failure. He was the president of ISG, Indian Association for the Study of Liver Disease, Asian Pacific Association of Liver, and chairman steering committee of APASL. He has received several awards and orations nationally as well as internationally. I'll request the chairpersons, Dr. Rajesh Gupta, Dr. Parimal Swami, Dr. Peeyush, Dr. Rajesh Gupta to initiate the session. Dr. Rajesh Gupta, please.
Yes, sir. At the outset, I would like to thank Dr. Manoria for involving me in this important session. And Dr. Manoria has already introduced, Dr. Sarin is one of the most well-renowned international hepatologists from India. He is the largest publication. In fact, he is my teacher and mentor like Dr. Manoria. And there is no better person than to speak on this topic of metabolic associated fatty liver disease. And this is, in fact, a new entity which is emerging as a major cause of chronic liver disease all over the world. And it is how we as physicians in the society should understand and identify these patients and treat appropriately. And there is no better person than Dr. Sarin to give the concepts to the physicians how to treat and deal with these patients. With these words, I will request Professor Sarin to start his deliberation.
Good morning. I'm grateful to Dr. Manoria for inviting me for this global cardiometabolic update. I bring greetings from the Institute of Liver and Biliary Sciences, and I'll share some experience on the metabolic dysfunction associated fatty liver disease. Let's see what liver does. You all know it, but still I will try. It tolerates all insults. It is the biggest lymphatic gland with largest number of immune tolerant cells, the NK cells of the innate immunity. It synthesizes proteins, vitamins, and stores all the calories. It detoxifies, it clots, it gives you bile, but most important, it controls your blood glucose. You remember that it is not pancreas, it is the liver. What damages liver? The fat, the alcohol, you know it, viruses, Hep B and C. You all know that drinking, you all know Nash, and you know the man who continued to drink because of her. So alcohol gives you fatty liver. If the weight of the liver has more than 10% fat, it is fatty liver. The other term is non-alcoholic fatty liver, steatohepatitis. Steato means fat, hepatitis means fat-induced hepatitis. So whether it is alcohol or it is fat, due to calories or obesity, it is steatohepatitis. So normal liver, less than 5% fat, and excess of 10% or more is fatty liver due to calories and genes. Countries which have 30% or more of Nash, MAFLD, are in red. And you can see India scores well into this. How does surplus fat produce injury? This liver fat causes inflammation, which is measured by raised ALT or SGPT, and extrahepatic organ involvements. Now, these are sets of very important slides, and I want you to pay attention. So, the alcohol or the fat in a person with liver will produce fatty liver. Steatosis, all these white cells are actually fat-containing cells. So there are very few normal hepatocytes. All others are fat-containing ballooned hepatocytes. Now the body's immunity, innate immunity, thinks what are these cells? ये कहाँ से आ गए? इनको मारो. To kill these cells, they send the inflammatory cells. So then you have inflammation. This is fat-induced hepatitis, steatohepatitis. Now there has to be some healing after the injury, and this lays down fibrous tissue. This is hepatic fibrosis. They can go hand in hand. And then finally, stage may come where cirrhosis or even liver cancer may develop. In fact, 2 to 12% of cirrhosis produce liver cancers. Fatty liver disease has high ALT. This is steatohepatitis. Now you can see that if there is increase in fat, there is difficulty of insulin to enter into the cell. So this fat containing cells, to produce ATP energy, insulin is required. But in this fatty cell, insulin cannot go. And this is insulin resistance. To overcome this, more and more insulin has to be produced. Finally, it leads to something called as diabetes. In fact, diabetes is a liver disease. What more, this fat in the liver, once the liver cells are filled, will go into the blood, and you have high cholesterol, high triglyceride. So anybody who has high cholesterol or triglyceride has fatty liver. This will deposit onto the arteries. You have atherosclerosis, heart disease, stroke, and gallbladder stone. So metabolic dysfunction associated fatty liver disease is a disease where liver and extrahepatic organs are involved. So liver fat flames and frames the body. Every organ of the body is affected by hepatic fat. This study from Korea, done in 1990 to 2092, and the patients were followed up till 2000, shows you relative risk of mortality. If the ALT levels are less than 20, it is okay. But if they go to 30 to 39, you can see liver-related deaths are several times higher. Even non-liver-related are higher. And if the levels go higher up, you can see that several-fold increased in liver-related mortality. Somebody has an ALT of 80, 30 times more risk of liver disease, and about 3 times of heart, kidney, brain diseases are there. This brought us to the concept of what should be the normal ALT. All labs do 40 or 45. We at ILBS do less than 30 or less than 19 as a normal ALT. This is, I think, most useful to remember. A high ALT increases the risk of developing diabetes by 5 to 20 times. This is a Framingham study where third-generation children, when they were studied, those who had high ALT developed diabetes several times more. A high ALT or SGPT, which is a marker of liver inflammation, relates to fatty liver disease, dyslipidemia, diabetes or risk of diabetes, hypertension, heart disease and the risk of heart disease, and all cancers, liver, breast, prostate. Ask yourself, how many of you have high ALT? If not, check it up and try to correct it. So the central thought is liver fat precedes flames, diabetes, and heart disease. So this is cardio-metabolic, or I would say hepato-metabolic concept. The person who is overweight or inactive, has obesity, will have fatty liver, has increased ALT, leads to diabetes. There is a sick adipose tissue, adiposopathy. There are increased lipids and decrease in the adiponectin, which is a good hormone. Hypertension, heart disease. There is a deposit of fat around the heart and poor pumping of the heart. Kidney disease in patients who have Nash. If there is no NAFLD, it is better. Free survival probability is more. But if a CKD patient has NAFLD, the outcomes over time, 5 years or so, are poor. Same is true for myocardial infarction and stroke. People who have got fatty liver, NAFLD, compared to the matched no NAFLD, have higher hazard ratio of developing infarction and stroke. Same is true for outcome. Say a person who has got COPD and has liver fibrosis due to Nash, the cardiac events are much more in these patients. Cancers, the lung cancer incidence is higher in those with Nash. The stomach cancer incidence is higher in those who have MAFLD. Liver cancer, now this shows you India. Of the total number of liver cancers, 35 to 40% of the cancers today in India are due to NAFLD. I'll show you some more data on this, but just to tell you, diabetics or those obesity have today the highest risk of liver cancer. So the core of all metabolic diseases starts from fat in the liver. Cardiovascular, hypertension, obesity, diabetes, polycystic ovary, sleep apnea, and cancers. Therefore, the bottom line is reduce fat in the liver. So, first question is, do I have fat? Should I worry? How to fix it? So, somebody who is overweight, of course, has a fatty liver and may have cirrhosis. Then somebody who is thin. If there is a strong family history or you are yourself suffering from metabolic syndrome, diabetes, hypertension, heart or kidney disease, liver, gallstone, cancers, obesity or snoring or have polycystic ovary, sure enough, you have fat in the liver. Or your weight is more. The formula is height minus 100 should be your weight. 170 minus 100 should be 70 kg for a 170 centimeter tall person. If there is a female, make it 105. So it should be 65. If there is a family history, reduce another 5. It should be 100 and it should be 60 kg for 170 centimeter to prevent having fatty liver. You check it by ultrasound, abdominal and a fibroscan if possible. Otherwise, simple ALT, lipids and blood sugar are enough. There are 3 types of people. This is first where there is nobody in the family has any predisposition. So he is the first generation guy. On him, even if he eats more, even if he has metabolic syndrome, there will be limited amount of fatty liver disease. So every foodie will not have fatty liver. But his grandchild, who is genetically now predisposed, with despite even limited exposure to extra fat or environmental factors, will develop fatty liver disease. So remember, you may not have it, but your grandchildren will suffer from what you do today. So live for your grandchildren. Don't make a mess of their life. Avoid fat today. Ultrasound will show you, like this is the skin. It has black and the underneath is the fat, subcutaneous fat. It is white. And you can see that liver and kidney. Liver is whiter than kidney. In fact, liver is whiter than spleen. So this is a fat in the liver and it is a fatty liver. It is rounded and it is maybe advanced fibrosis. This is found out by fibroscan, which is a simple ultrasound machine. It gives you the amount of fat. CAP is controlled attenuation parameter. The sound wave goes in and returns. It is attenuated based on the amount of fat. So CAP tells you how much fat. It should be less than 250. 306 means somewhere like 30 to 50% of the liver has fat. And this is fibrosis in fibroscan. This is the time in milliseconds. Normally it should be 60 milliseconds. The harder the liver, faster the sound returns. So if it is 40 milliseconds, then fibrosis is 8.5 kilopascal. It is like stage 2 fibrosis of the liver. So in 1 minute, you know fat and fibrosis. How do you treat? Well, you have to change your attitude. If somebody has fatty liver, they say, "Arey bhai, kya farak padta hai? Itne logon ke hai, tumhe bhi hai, chalne do." That chalne do wali approach has to be changed. Liver fat is an alarm. Please listen to the alarm. Therefore, avoid further insults to the liver. Wait exercise to help you, and food to make your liver not insulted. I told you about the ideal body weight, 5% less if there is a family history. Lightweight, the best policy. You will prevent fatty liver, diabetes, heart and kidney disease. This is to show you that if somebody loses on 600 kilocalories diet, in 1 week's time, liver fat from 13% comes to 10, and in 4 weeks to just about 5%. So if you work hard on a very low calorie diet for 4 weeks, you can, whether you do intermittent fasting or anyway, you need to reduce intake. This is to show that in this 36% of the liver had fat, 36% liver fat content. But after reducing on low calorie diet, as I showed before, liver fat is just about 2% or so. Focus on health. This is an important diagram to show you whenever we take glucose, it goes, or any form of sugars or calories, they will go into the liver. The sugar will be converted, if in excess, into storage by lipogenesis. And also it will go to the muscle where it will be utilized. So in a healthy liver, the glucose converts into glycogen, and in the muscles it will be utilized. The excess of glucose, if there is no activity in the muscle, if it is insulin resistant, all the sugar will go to the liver. So this extra sugar diverted from liver will cause fatty liver, and also there is increased triglycerides. A 15 minutes of exercise makes the muscle from insulin resistant to insulin sensitive. And that is how you can remove fatty liver. It will decrease triglycerides, it will improve the HDL. Exercise is therefore required. How do you test for it? You have primary health center. In a primary health center, PHC level, you can take the history. Then you do a FIB4. FIB4 is very simple. You need age, AST, platelet and ALT. Any LFT plus age, you can detect FIB4. If FIB4 is less than 1.3, it is good. If it is more, you start worrying, and this patient can further be referred for a fibroscan or something else. Now I come to the MAFLD. NAFLD was the term we all had grown up with. But now, metabolic dysfunction associated fatty liver disease is the new term. And these are Asian guidelines. Who has MAFLD? Anybody who is overweight, has a BMI about 23 or is obese, or has type 2 diabetes. All these people, every diabetic has fatty liver, and overweight and obese have a metabolic associated fatty liver dysfunction. Now it is only the lean or normal weight, less than 23. In them the metabolic factors are important, like waist, blood pressure, TG, HDL. All these which we used to believe now are meant for normal or lean weight persons. So MAFLD is a metabolic associated fatty liver disease. It includes some amount of alcohol, mild to moderate, but most of us believe this is the best scenario. So you remember this figure and you will diagnose easily MAFLD. Now obesity can be of different types. Somebody may have a BMI of more than or equal to 30, but maybe metabolically healthy. This is the first generation guy. And here can be somebody who is sarcopenic, but is metabolically unhealthy. Now look at the normal weight guy. A normal weight guy, 18.5 to I would say 23 in Asia, is healthy and lean. But he can be metabolically obese. His visceral fat, subcutaneous fat, his extrahepatic fat is unhealthy. We now need to worry. India has close to 40% of people who will be lean but are unhealthy metabolically. What efforts is India making for this? So there is an initiative by India, first country in the world where NAFLD is included into the national program for control of kidney disease, diabetes, stroke, cardiovascular diseases. This now is part of all the states are implementing this program. Since liver is the core, let it remain as the core of the whole thing. You have to remember your diet. It all depends on the plate. You become what, how much, and when you eat. So keep your bacteria silent. Bacteria is what they signal what you are eating. Remember to have plant-based diet, colored vegetables, apple, ghee, all these are Indian diets. Walnut, haldi, and coffee, which can clear the fat from the liver. Where there is a will, there is a way. There is some hope. India starts it. I want each one of you as physicians, as cardiologists, as diabetologists, to start as number one. You are the one who will go to the society and shoot. You have very limited space, very poor infrastructure. Doesn't matter. Teach one, they will teach 10. Include children, include females. And remember, your one shot will go to many, many more people. I think this is the way, if you collect the right audience, you teach each one of them to shoot, the India will change. With this, I would like to thank you one more time for inviting me.
Dr. Sarin, is fatty liver the cause of diabetes or diabetes the cause of fatty liver?
You have asked a very important chicken and egg question. But by and large, 10 years ahead of diabetes, you get fatty liver, and persistence insulin resistance gradually leads to development of diabetes. So like in the Japanese population, almost 15 years ahead of time, they have shown that if you detect diabetes, if you detect fatty liver, you can prevent development of diabetes. So my opinion is clear, fatty liver precedes diabetes.
The second issue, should a patient of acute myocardial infarction who is non-diabetic, is not obese, get a liver scan for fatty liver?
Yeah, he should get a liver scan, fibro scan. There are two types. One is lean and one is guy. The lean person generally has more of visceral fat. So the BMI may still be 23, but the proportion of white fat may be much more. And therefore, those who get coronary definitely should go for liver scan, liver fat, and it is advised of their weight so that the fat in the liver goes down.
What about CKD patients?
Well, CKD, once they have developed CKD, the only advantage of weight reduction or removal of fat can be to prevent concurrent fibrosis and ongoing liver disease. However, if you want to prevent development of CKD, then all these people with a creatinine of 1 or 1.1 should be checked, and so all those who are stage 1, 2 early kind of patients, in them prevention and treatment of fatty liver will prevent progression to CKD 3 or 4.
Chairpersons for questions and comments.
Sir, is lean Nash more aggressive than obese Nash? There's some reports like that.
Firstly, the term lean Nash has now been gradually replaced by normal weight Nash or normal weight MAFLD, and it is more aggressive in the sense that there is at least 3 generations of epigenetic and genetic modulation. So they have more aggressive disease and much higher chance of liver cancer.
Dr. Swami here, very masterful presentation, sir, as usual. Just 2 questions. We all know that there are no sort of a proper drug treatment for NAFLD or MAFLD. What about saroglitazar? I heard that it has been approved for the treatment of fatty liver disease in India. So what's your take on that?
Dr. Swami, thank you. Firstly, the drug treatment for obese diabetic because every diabetic has fatty liver. So obese diabetic, the first drug of choice is metformin, and now semaglutide or even SGLT2 inhibitors can be tried in these patients because they will decrease dyslipidemia and other. This is a diabetic with liver involvement. Now, there is another group who is just dyslipidemia, has F2, F3 fibrosis, and maybe NAFLD. For them, saroglitazole is a very good drug. It is alpha delta combination, it is alpha gamma combination. It decreases the hepatic fat, triglycerides, and even reverses the fibrosis to some extent. However, it should not be given if a patient has already developed cirrhosis. So a diabetic with cirrhosis, NAFLD with cirrhosis, drug of first choice is metformin. And you can try with this pentoxifylline, which removes the fat. We have published enough on this. For others, F2, F3 fibrosis, saroglitazole. You can also try vitamin E, which can be given for 2 years, and ursodeoxycholic acid. Newer drugs are coming in like obeticholic acid and others, but we need to have more data on that.
Thank you, sir. Thank you very much.
So with this, we conclude this session.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.